Valvular heart disease involves damage or a defect in one or more of the four valves of the heart. So, the aortic and bicuspid or mitral valves on the left side of the heart, and the pulmonary and tricuspid valves on the right side of the heart. Normally, the valvular leaflets are very thin, and when the cusps close, they're perfectly opposed. Valvular heart diseases are divided into stenosis, in which there's a narrowing of the valvular orifice that prevents adequate outflow of blood, and insufficiency or regurgitation, in which the valvular leaflets fail to close correctly and are unable to prevent backflow of blood. These two are not mutually exclusive, which means they can both be present in the same individual and even in the same valve. For instance, if thickening of the leaflets results in inappropriate closure as well as a narrow orifice. Individuals with valvular heart disease are generally asymptomatic for a prolonged period, even for decades, and as soon as they become symptomatic, their life expectancy deteriorates very quickly. The main symptoms are dyspnea, syncope, and angina. Both stenosis and regurgitation lead to turbulent flow when blood flows across the affected valve, which produces heart sounds called pathologic murmurs that are loud enough to be heard upon auscultation with a stethoscope. When presentation suggests valvular heart disease, you should proceed with echocardiography to confirm the diagnosis of valvular disease and determine its severity. A transthoracic echocardiogram is typically done, but a transesophageal echocardiogram may be needed in selected individuals, like those with a non-diagnostic transthoracic echocardiogram. Doppler echocardiography allows determination of the speed and direction of blood flow, which makes it the most sensitive non-invasive technique for detecting the regurgitant jet. In some cases, cardiovascular magnetic resonance imaging may be indicated to quantify the severity, measure left ventricular diastolic and systolic volumes, and assess left ventricular systolic function. And as a last resort, cardiac catheterization is indicated when non-invasive tests are inconclusive or provide discrepant results, or for coronary angiography prior to valve surgery in patients at risk for coronary disease. Cardiac catheterization allows you to measure pressure waveforms, which are indirect measurements of the left atrial pressure. Alright, on to aortic stenosis, which is the most common cause of valvular heart disease. Typically, the three leaflets of the aortic valve get thick and calcified and don't open all the way, making it harder to pump blood out of the body. Most often, the aortic valve is tricuspid, but in some people, it may be unicuspid, bicuspid, or quadricuspid. Valves with a different number of cusps than tricuspid degenerate much more easily. Valve degeneration is usually due to wear and tear and atherosclerosis, so these patients tend to be older. In aortic stenosis, the pulse is described as being parvus and tardus. That's because the valve doesn't fully open, so there's less blood flow, and the pulse is weak, parvus. And there's a delay in the opening of the valve, which causes a mid-systolic crescendo-decrescendo murmur that occurs a bit later than expected in systole, tardus. This murmur mirrors the ejection of blood from the ventricle into the aorta. It increases with increasing pressure of ejection and decreases as ejection pressure decreases. In aortic stenosis, thicker leaflets due to calcification are usually visible, as calcium on echo is bright white, and the opening of the valve is also greatly reduced. Doppler echocardiography permits measurement of jet velocity of blood and calculation of the left ventricular aortic gradient and the valve area, which are the standard parameters used for evaluation of stenosis severity. The flow is very turbulent because of the stenotic valve, presenting as elevated jet velocity. Blood pressure gradient is useful to understand the severity of the stenosis. Usually, the cutoff is a mean gradient higher than 40 millimeters of mercury. The more severe the aortic stenosis, the higher the blood pressure gradient. Asymptomatic individuals aren't treated, while symptomatic aortic stenosis is an indication for aortic valve replacement, choosing from manufactured mechanical valves, human donor valves, or tissue valves created from animal tissue. Aortic valve replacement can be done either through open heart surgery with surgical aortic valve replacement, or SAVR, or through transcatheter aortic valve implantation, or TAVI, which involves placing the valve through a catheter, typically through the transfemoral route in the upper leg. SAVR and TAVI should be used in individuals who are likely to have a prolonged life expectancy of at least a year, as well as an improved quality of life. For those individuals, the benefits should be weighed against the risk of the procedure. For individuals with low surgical risk, or if transfemoral TAVI is not feasible, SAVR is performed. For individuals with intermediate or high surgical risk, or if SAVR is contraindicated, then TAVI is performed. Medical therapy has limited utility in treating aortic stenosis, so it's given as a last resort to individuals that are not candidates for aortic valve replacement. The medications used include digoxin, diuretics, ACE inhibitors, or angiotensin receptor blockers. Now, in aortic regurgitation, the valve doesn't close all the way during diastole, and blood leaks back from the aorta into the left ventricle. That leads to progressive ventricular dilation to accommodate the increased blood volume. The valve leaflets may be abnormal or may be normal but stretched apart due to dilation of the ascending aorta. Abnormalities that may be seen include thickening, vegetations, calcification, and prolapsed or flail leaflets. On physical examination, aortic regurgitation causes a collapsing pulse or water hammer pulse. To feel it, the individual must lie back and raise their arm vertically upward, and the examiner has to grasp the muscular part of the patient's forearm. A water hammer pulse is felt as a tapping impulse that's felt through the bulk of the muscles, because the blood that is pumped to the arm during systole is emptied back into the heart during diastole due to the effect of gravity on the raised arm. Upon auscultation, there's an early diastolic murmur due to the backflow, and since there's more volume in the left ventricle when it contracts, there's also an ejection systolic murmur. The severity of aortic regurgitation is determined through echocardiography or cardiac magnetic resonance imaging, which specifically look at the volume of blood flowing back into the left ventricle with each beat. The mainstay of treatment is aortic valve surgery, which is indicated in severe aortic regurgitation. But if aortic regurgitation is not severe, or even if it's severe but doesn't cause left ventricular dysfunction, then surgery isn't recommended. Instead, the individual is given medications like ACE inhibitors, angiotensin receptor blockers, or vasodilators if they have hypertension. Now, if there's severe aortic regurgitation and left ventricle impairment, and if the surgical risk is low, then aortic valve surgery is recommended. Alternatively, if individuals have another indication for cardiac surgery, like concomitant disease of another valve, then aortic valve surgery may be done independently of severity. Moving on to mitral regurgitation, it's caused by imperfect closure of the mitral valve during systole, which causes backflow of blood from the left ventricle into the left atrium. This volume overload leads to an increase in left atrium pressure, which can cause pulmonary hypertension due to backward pressure transmission, and eventually leads to atrial dilation. When that happens, the muscle walls stretch and the pacemaker cells that run through the walls become more irritable, increasing the risk of atrial fibrillation. And atrial fibrillation can lead to blood stagnation and thrombus formation, which can then flow into the systemic circulation, potentially leading to a stroke. Upon auscultation, a pansystolic murmur can be heard. Mitral regurgitation is classified as either primary when it's due to valve damage or abnormality, or secondary or functional when it's due to a ventricular dysfunction or abnormality that causes valvular dysfunction without damage to the valve itself, such as left ventricular dysfunction or dilation. For individuals with or without symptoms that have primary mitral regurgitation, the definitive treatment is valve replacement. But valve replacement comes with an increased risk of thrombosis, embolism, and endocarditis, so the decision has to be carefully weighed out. When mitral valve replacement is required, a choice is made between a mechanical or bioprosthetic valve. Mechanical valves have the disadvantage of requiring lifelong anticoagulation therapy with warfarin, while bioprosthetic valves have the disadvantage of limited durability due to valve degeneration, and that's particularly relevant in individuals under the age of 65. Now, if the valve is not too damaged, then mitral valve repair is preferred to mitral valve replacement. And the valve repair can be done either through open heart surgery or as a transcatheter mitral valve repair. And for those who can't undergo repair or replacement, medical therapy with diuretics, digoxin, and ACE inhibitors is typically done. But medical therapy helps to alleviate the symptoms, and it doesn't stop disease progression. In case of mitral stenosis, the leaflets can fuse together, so the mitral valve doesn't open enough. This makes it a lot harder for blood to flow from the left atrium to left ventricle, leading to higher pressures in the left atrium. To compensate for the increased resistance of the valve, there's left atrial hypertrophy and dilation. A constant elevation in both blood volume and pressure in the left atrium causes it to dilate and can allow blood to back up into the pulmonary circulation, causing pulmonary congestion and pulmonary edema. All this extra blood volume in the pulmonary circulation causes pulmonary hypertension, which can ultimately make it harder for the right ventricle to pump blood to the lungs. And over time, the right ventricle can hypertrophy and ultimately fail, which is called right-sided heart failure. A typical feature of mitral stenosis is the strong pulsation that is seen in the left part of the heart due to stenosis during the second heart sound in diastole. On auscultation, mitral stenosis causes a low-pitched, mid to late diastolic murmur. On echocardiography, there's left atrial enlargement, thick and calcified mitral valve with narrow orifice, and increased blood flow velocity during diastole. The transmitral pressure gradient, as measured by Doppler echocardiography, is the gold standard for diagnosis, allowing classification of mitral stenosis as mild if lower than 5 millimeters of mercury, moderate if between 5 millimeters of mercury and 10 millimeters of mercury, and severe if higher than 10 millimeters of mercury. The most common cause of mitral stenosis is rheumatic fever, mainly affecting children and young adults in developing countries. The treatment options for mitral stenosis include mitral valve replacement by surgery and percutaneous mitral valvuloplasty, which is a minimally invasive therapeutic procedure that opens the orifice by dilating the valve using a balloon. Determining which patients would benefit from percutaneous mitral valvuloplasty relies on 4 echocardiographic criteria: leaflet mobility, leaflet thickening, subvalvular thickening, and calcification. Treatment is chosen based on the presence of symptoms. In asymptomatic individuals with a low risk of thrombosis, percutaneous mitral valvuloplasty is done. If there are contraindications for percutaneous mitral valvuloplasty, the individual will be followed up for at least 6 months. In symptomatic cases of mitral stenosis, percutaneous mitral valvuloplasty is performed, and if there are contraindications, then open surgery is recommended. Alright, on to the tricuspid valve. Tricuspid regurgitation occurs when the valve can't close adequately, resulting in the backward leakage of blood from the right ventricle into the right atrium with each heartbeat. And tricuspid stenosis is an extremely rare condition in which the valve may become stiff and narrowed, impairing the forward flow of blood from the atrium to the ventricle. Tricuspid valve diseases, so both regurgitation and stenosis, typically don't cause symptoms until they become severe, and they eventually lead to an increased pressure in the right atrium. Symptomatic individuals might have distended neck veins, swelling of the ankles and feet, and hepatosplenomegaly, reflecting the backflow of blood from the right side of the heart. Treatment aims at maintaining good fluid balance by giving medications like diuretics. Tricuspid valve surgery is only indicated in rare, severely symptomatic cases, or in those already getting surgery for another heart condition. Finally, there's the pulmonary valve. Pulmonary stenosis makes it harder for the heart to pump blood to the lungs, and that causes symptoms like cyanosis, dyspnea, and fatigue, which are most noticeable during exercise. Pulmonary stenosis is generally congenital, but unless the degree of stenosis is severe, individuals with pulmonary stenosis usually don't require intervention until later in adulthood. Treatment of pulmonary valve stenosis usually involves a balloon valvuloplasty, which means that a balloon is inserted and then inflated to open the narrowed valve and allow more blood flow through it. On the other hand, in pulmonary valve regurgitation, blood leaks back into the right ventricle. Over time, pulmonary valve regurgitation can lead to right-sided heart failure, which can cause the blood to back up, and symptoms like distended neck veins, swelling of the ankles and feet, and hepatosplenomegaly. Treatment for pulmonary regurgitation is usually valve repair or replacement if right-sided heart failure develops. Alright, as a quick recap. Aortic stenosis presents with parvus and tardus, mid-systolic crescendo-decrescendo murmur, and a higher blood gradient. The blood pressure gradient cutoff is a mean gradient higher than 40 millimeters of mercury, and the more severe the aortic stenosis, the higher the blood pressure gradient. Aortic regurgitation presents a collapsing pulse, or water hammer pulse, an early diastolic murmur, and an ejection systolic murmur. Mitral regurgitation presents a pansystolic murmur, while mitral stenosis presents a mid to late diastolic murmur, but both cause pulmonary hypertension. The transmitral pressure gradient allows classification of mitral stenosis as mild if lower than 5 millimeters of mercury, moderate if between 5 and 10, and severe if higher than 10. Tricuspid and pulmonary valve disease mainly cause leg swelling, hepatomegaly, and distended neck veins. Echocardiography is then performed to confirm diagnosis of valvular heart disease, as well as an evaluation of severity and treatment choice. Treatment generally involves either valvular repair or replacement.